Hello everyone, my name is Joanny. I'm a second year physician associate student studying in London, and today I'm going to be telling you guys all about my geriatric medicine or care of the elderly placement. So some of you may know that I started second year September, and it's my final year of PA school, and we only have hospital-based placements this year, and my very first rotation was the care of the elderly placement or geriatric medicine. So we have 3 weeks for most of the core placements. We have 12 weeks in AMU, 9 weeks in GP, 6 weeks in ED or A&E, and 3 weeks for everything else. So most people start with AMU or general medicine or acute medicine, but I started with care of the elderly or geriatric medicine. So I've just finished my 3 weeks, so my first rotation, and I thought I'd tell you guys all about my experience and maybe share some tips as well and some things that I've learned from the last 3 weeks of being in hospital. So some of you guys may know that last year in first year we did not have hospital-based placements at all. So we had GP placements once every week, so every Wednesday. This was something that was totally new to us, and they just let us into the deep end. We were kind of prepared. They taught us all the different procedural skills and kind of prepped us about what the ward is going to be like. And we even had second year PA students, actually PA students who had just finished their second year, who had written the national exam. They came in and they spoke to us all about what to expect on the wards and what to do in each of the different placements. So we kind of were prepared, or kind of knew what to expect in a way when we got on the wards. I personally was a bit scared. I was a bit terrified. I don't know why, but I just felt like being a student on the ward where there's so many different people, I just felt like I'll meet people who weren't very nice, and because I'd heard so many tragic stories about how some PA students can be treated on the ward and stuff, and so I had this kind of idea that if I go on the wards, I might meet mean consultants and people who didn't appreciate the role, and I don't do very well under pressure. I was hopeful, but again I had this kind of fear at the back of my mind, thinking it might not go well. So I was kind of like bracing myself for the worst, so preparing myself for the worst but hoping for the best, you'd say. Hoping for the best but expecting the worst. That's what's happened. But I've had an amazing 3 weeks, I would say. My first 3 weeks have been absolutely amazing. The very first thing that I prayed for before going on my placement was just that God gives me favor everywhere I went. So every person I worked with or any person I came across, I just prayed for favor. Every single day that I'll go to placement, I'll pray, God, please just grant me favor. Whoever I work with, just help them to be willing to teach me, give me the confidence to, just put myself out there and not be afraid to do stuff and to say stuff. Yeah, so on the very first week, we went on the very first day. We had our induction day. I'm just looking down at my notes just so I don't leave out anything. I divided it into each week, so I want to tell you guys everything that I learned throughout the placement. Induction day, we had talks about infection, we had infection control, sepsis, and then they told us about our IT logins, how we had to sign up for that. But I had a lot of problems with my IT login because apparently there was a glitch in the system, and then my name wasn't found in the system, so I couldn't get my IT login, and I haven't even gotten it up till now. So I have to make sure that when I go back there next week, I can be able to get my IT login. But anyway, it was really good to see my friends. So like I said, I was on placement with some of my friends. There were 4 of us in the care of the elderly rotation, but then there were 4 other people four other PA students in the AMU rotation. So I used to see my friends during lunchtime. I'll have lunch with them, and it was great. In the first week, I worked in the ACE clinic. So ACE stands for acute care of the elderly. So the ACE clinic was found within one of the wards, within one of the elderly care wards in the hospital. And the aim of this clinic was, it worked kind of like GP, like a GP setting. You had a doctor there and a GP, or sometimes you had a GP on their own or a doctor on their own, depending on you know, the rota and everything like that. And what happened is that you had patients that could book in to come to this clinic, or GPs could refer people to this clinic, or from wards as well as outpatients. They come into the clinic and they see them for acute problems, and the aim of the clinic is so that they can the doctors can see them, do necessary investigations, and, you know, manage them without them having to be admitted in hospital. So it was really good. I sat in with doctors and the GPs as well. It was a bit of a slow beginning at the start of the week, because there weren't that many patients to begin with, so it was a bit of a slow beginning. I was just trying to get my head around how everything works, but it kind of works like GP. It's just that they see more complex patients, patients that you would never be able to manage within 10 minutes or 15 minutes in a GP setting. So they spend a lot of time with the patients. Doctors spend a lot of time with the patient. They had a lot of time to take a full history, do all the examinations, and then do the investigations, do like blood tests and scans and everything within one day. So I thought that was really good. I sat in with the doctors. I took blood. So I took bloods for the first time. The nurses watched me for that first week, but then later on I learned how to take the bloods on my own unsupervised. I got signed off for that, and I also interpreted ECGs with one of the GPs. I think he taught me how to spot a systolic murmur. So there were different conditions that I came across with all the different patients that we had, conditions like multiple myeloma, which is the cancer of the blood cells, conditions like cellulitis, DVT, colorectal cancer, postural hypotension, dementia, and aortic regurgitation as well. I heard a murmur, an aortic regurgitation murmur for the first time. I think that was the first time I was hearing a murmur, which was kind of cool, really. So yeah, that was good. The patients were really lovely. They kept complimenting me and kept saying how nice I was. I remember the very first patient I took blood from, he gave me a 10 out of 10. I'm pretty sure I wasn't a 10 out of 10 because I felt like my hands were like this, like I was holding the needle like this, and the nurse was watching me. I was like, oh my god, I hope it's an easy bleed and that I don't hurt the patient or whatever. But the patient was really nice. He was like 10 out of 10 for effort, 10 out of 10 for everything. I was like, oh, you're so nice. Moving on to week 2, I went on to a general geriatric ward. The patients were admitted with different conditions, so it was just a general geriatric ward. It worked kind of different to the ACE clinic, obviously, because the ACE clinic was a clinic. So I just turned up in the morning, and then I was with the doctor as the doctor saw patients throughout the day. But obviously, in my second week, I was actually on a ward. So when the first week came in the morning around 9 o'clock, I followed the doctors to a meeting where they just went around each of the different elderly care wards and asked about staffing, like how many registrars they had on the ward, how many F1s they had on the ward, how many junior doctors, or who was on the ward pretty much, and if they needed to move people around, they'd move people around to help out on different wards. So they had that meeting first thing in the morning, which was 9 o'clock, and then at 9:30 they had a what they called a huddle, so like a morning huddle where the doctors and the nurses just met in front of the nurses station, and then the nurses just handed over to the doctors who they thought, which patients they were worried about, if there were any new patients overnight, and if there's anything they wanted to really hand over to the doctors first, or which patients were going home, and so the doctors would see those patients first before the ward round. So they did that in the morning huddle. I thought it was really cute. And then after that, the doctors broke off for the ward round. Usually they split it in half, and I would go with one consultant. So one consultant sees the men and the other consultant sees the ladies, and would go around the ward round, see all the patients, and then at 12 o'clock, everyone tried to finish their ward rounds by 12 o'clock. At 12 o'clock, they had the board meeting or MDT meeting. I think it was like a board meeting, and you had all the different members of the MDT were present. So there's loads of people you had the ward clerk who was present, you had the doctors, you had the nurses, or the nurse in charge who was present, you had the physios, the OTs, so the physiotherapist, the occupational therapist, the social worker as well who was present. They would go through each of the patients and talk about them. So the doctors would present what they found during the ward round, and then they would talk about discharge planning. The physios would give their input to see how the patient is and how their mobility is, and then the occupational therapist would give their input about their functional needs, if they need any equipment at home. The OT would talk about that. Then the social worker, she would give input about if the patient needs any package of care at home, or if there's anything else that needs to be sorted in terms of care. Really, the social worker would talk about that. So it was a very good way to see how each member of the MDT comes together to help the patient. I thought that was really cool to see that, to be part of that. And also the ward clerk as well, you know, she was also very busy, you know, calling up, arranging meetings, calling up people, arranging things outside the ward. So yeah, it was really cool to see that. I did my first ABG, so arterial blood gas. If you don't know what that is, you can watch one of my previous vlogs. I think the one where I titled swine, stitches, airways and something, when we learned how to do ABGs and all of that stuff. And I did my first ABG on a patient and I got it first time, guys. I got it first time. Like, even the doctor was like he didn't even believe that I got it first time. Literally, it's so painful because you take it from an artery rather than a vein. And yeah, I literally went in and the blood just came out. I was like, yes, thank you, Jesus. Honestly, like, I was so happy. Anyway, I got that signed off. I did I catheterized a male patient as well, and I got that signed off. And then I started taking bloods unsupervised. Once they watched me once and then they saw that I could do it, they let me do it on my own. So I took bloods, like, I just really helped them. Every time a patient needed bloods to be taken, I just, went ahead and did it. I felt like I was part of the team because during the ward rounds, the consultant would be like, okay, when they write it on the plan, the consultant goes round and then she would speak to the patient, examine the patient. The junior doctor would be documenting what's going on during the ward round. And then sometimes they would ask me questions as well during the ward round. And then if anything needed to be done, like bloods, or if they needed to call a scan, for example, the consultant asked me one time to phone X-ray to come and do an abdominal X-ray on a patient, or to come and take a patient to go do an abdominal X-ray, and I had to call up X-ray. And oh my gosh, I was like, oh my gosh, why is she telling me to call X-ray? Like, what if I say the wrong thing? Like, but yeah, it was, once I did it, I found that, it's actually not that deep. It's just to call them and to say, please, can you come and take this patient to go do an X-ray? So it wasn't that deep. But if any patient needed any bloods, they would say, yeah, no, Joan can do it. And so I just went around doing the bloods, and then I'll join them back in the ward round. So yeah, I felt like part of the team, and I would do the bloods, send them off, and then the results would come back, and I was like, oh, I did those bloods. So yeah, it was just, yeah, I just felt like part of the team. It was very challenging to find patients to clerk because obviously on that ward, a lot of the patients were, a lot of the patients had dementia. A lot of them didn't have capacity to give you like a good history. So I didn't have the opportunity to properly clerk patients. So take a full history from them and examine them and do all of those things. So it was challenging while I was on that ward. But it's okay though, because when I move on to the next specialty, obviously I'll have more opportunities to clerk patients. So with care of the elderly, it's just a little bit tricky. I really felt part of the team. The doctors were really nice. They were willing to teach me. The consultants were really nice. Yes, they quizzed me during ward rounds, but if I didn't know, I didn't know. But I managed to still answer questions and stuff. And yeah, they were really nice. All the nurses thought I was an F1. Like, a lot of the nurses thought I was an F1 because obviously I was going around doing all the bloods and stuff, and F1s usually do all of that stuff, apparently. So yeah, they were like, are you the new F1? I was like, no, I'm a physician associate student. And then I had to tell them what PAs are, and they were like, yeah, we know you guys, we love you guys are always very willing to do stuff. They actually love PAs, at the hospital I'm at. They actually love PAs, because they've had PA students before, and we have a reputation for always like being part of the team and helping out. And I thought that was really good, because I was like, what, I'm upholding the standard for PA students, like always being there to help. And because we have to be there, we have a set number of hours that we have to be. We can't just leave like med students do, like when they're bored. We have to stay there and actually get our hands dirty and do stuff and ask to do stuff and help out. So they actually do love PA students for that. some of the conditions I came across during the second week are like Parkinson's disease. There was a lot of patients that came in with delirium. And moving on to week 3, I went on to the stroke rehab ward. So this was really very cool because that's where my supervisor was on that ward. My supervisor, one of the consultants, she was there. And in the stroke rehab ward, they only treat patients who have had a stroke, who have had the initial treatment, whether it's a thrombolysis or a thrombectomy, and then these patients are transferred to the stroke rehab ward, and then they undergo intense therapy. So you have all of these patients who come in and they the therapist help them to get back to their baseline, or just to help them to recover from the stroke that they've had, and they have like intense physio, and it just helps them, you know, get back to their baseline. So I thought that was really cool. The day on this ward was slightly different from the previous ward I'd come in from. They had their board meeting in the morning, where so they had all the different the physios, the OTs, the social workers, the doctors, nurses, the nurse in charge, and the sister, the ward sister. Oh, she was such a boss. I loved her. The ward sisters, like, they literally rule the ward. Like, they are the bosses, like the boss. And they come in and they would hand over the patients to the doctors and everyone. They talk about the patients. The OTs, physios were giving their input, talk about all the patients, and then they would go on ward round. So ward round usually started around 10 or so, and then usually finished around 11:30ish, 12ish. And then obviously there would be a list of jobs that they would make up as they go during the ward round, the jobs for each patient. They'll make a jobs list, and then in the afternoon we would usually go back and do these jobs. So the jobs could be to maybe phone a family member, or to chase up some bloods, or to do some bloods, or to refer a patient for this, or to do a scan on this. So, you know, loads of those different jobs for each patient, and we had to do those in the afternoon. The afternoons were quite quiet, but there were loads of things to do. There's a lot of admin side to medicine. There's a lot of discharge summaries, a lot of repatriation, clerking things that you have to do. So I was taught how to do a discharge summary. I did 3 one day, and my head was like literally throbbing by the time I left. They're so long, and I don't want to do them. Some of the conditions were mainly stroke, really. We had some non-stroke patients that were on the ward, but they were mainly stroke patients, really. So I learned how to interpret ECGs when I sat in the TIA clinic. So we have a TIA clinic within that ward. TIA is a transient ischemic attack. So you have symptoms similar to a stroke, but the difference between a TIA and a stroke is that with a TIA, the symptoms resolve within 24 hours. So patients who think they've had a TIA would come to the clinic, or they will be referred to the clinic, or might be referred from A&E, might be referred from the GP to the clinic, and then the doctor would see them, take a history from them, examine them, determine whether or not they had a stroke, whether or not they had a TIA, and then order some investigations, and then they will go from there on how to manage the patient. They usually did an MRI scan of the brain. I did a scan of the neck as well to see if there's any carotid stenosis, because if there's narrowing in the carotid arteries by atheromas or something, there's a good chance that those clots could like break off and go to the brain and cause a stroke. So they usually do an MRI of the carotid arteries of the brain to see if there's actually a stroke, and just to see if there's a risk of you getting a stroke, because if you do have a TIA, there's a big risk that you would have a stroke in the future. So it's trying to manage these patients, whether if you want to put them on anticoagulants, or things like aspirin and clopidogrel to help to prevent them from getting a stroke in the future, or if they have risk factors, like for example if they're obese, or if they have diabetes, or just loads of other risk factors, or if they have atrial fibrillation, which is a risk factor for stroke. So you would put all these risk factors together to try and help the patient to prevent them from having a stroke. So that was the main focus of the TIA clinic. On the second day that I helped out there, the healthcare assistant was off sick, so I had to do the ECGs for the patients and do the OBS for the patients and just help the doctor out. It was such a busy day, and I was so tired by the end of it, but I learned a lot. I learned loads, because people came in with loads of different what's it called, symptoms, and I just watched the doctor take a history and try to decipher whether or not they had a TIA and then what to do next. So I thought that was really good. So some of the tips that I would say for geriatric medicine: know the common conditions that affect elderly like older people. So things like, you know, Parkinson's, dementia, so like a fall, like instability, what can cause reduced mobility for patients, what can cause falls, so things like stroke and all these other different conditions that are common in the elderly population. It's good to have an idea of these things before you start your geriatric medicine placement. Things like kidney function, like acute kidney injury, CKD, AKI, all of those things, how to stage them, what they mean. Yeah, it's just good to know about these things, really. And I know it might be boring in the afternoons because elderly care it can be quite slow depending on where you are, but like I would say take an opportunity to do stuff, like ask them to teach you things, ask them to teach you how to do discharge summaries or clocking, how to use the system. If they do everything online, like in the hospital I'm at, they do everything online, the system, so you ask them to teach you how to navigate the system. Because it might be similar in different hospitals, or if they're still using like paper documentations, ask them to show you how to document stuff. Speak to patients, if patients who are with it, you know, take a history from them, clock them, examine them, do all your clinical signs, your examinations, you know, speak to the patients, listen to their chest, listen to their hearts, you know, look at their blood results, go through scans, you know, with the patient, with the doctors, and ask them to teach you things. Ask questions if you don't understand what's going on. Don't just be quiet, ask questions. And you know, take opportunities and do stuff. If they ask you to call up x-ray and order a CT or whatever, or request them to come and x-ray a patient, do it. If they ask you to do a bladder scan, you know, do it. Put yourself out there and do it. It might sound scary, but you can do it, and they wouldn't ask you if they didn't think you could do it. So yeah. And if your ward has any clinics, so like a TIA clinic or ACE clinic, sit in those clinics and just to see how those different things are. If they have different wards, for example, the orthopedic geriatric wards and stroke wards and all of that stuff, try and like ask if you can rotate around all the different geriatric wards so you can see how different things work, because things work slightly differently even though it's all elderly care and all geriatric medicine. So yeah, overall general consensus, like I said, I had a lovely time. I met lovely people. I loved my supervisor. I loved the doctors I worked with. There was a lovely team. They included me. They appreciated my role, which was good. And some people who didn't know about PAs, when I told them about it, they were very receptive to it, and they weren't mean to me or try to be condescending or whatever. So I thought I had a good experience. Don't think geriatric medicine is for me though, because I think I'm glad that the 3 weeks is over. Like I said, I get bored really easily if I'm gonna keep seeing the same things over and over and over again. I prefer the GP. Again, I'm gonna try and compare everything to GP, because I'm sorry, in GP you see a wide variety of things. Yes, you see the older patients, and then you see the younger patients as well, middle-aged people, and everything's just so different. It keeps your brain working. Elderly care, yes, you know, every patient's different, but it's kind of like the same kind of diseases that you see all the time. And yeah, I don't think geriatric medicine is for me, but I love looking after older people though. So yeah, my shoes were amazing. Those shoes I bought that I told you guys, like, they really helped me survive the ward rounds, because you know the ward rounds you have to stand for a long amount of time. My feet didn't hurt, and I'm so glad. I'm so happy for that, and I love those shoes. They were so comfortable. And yeah, so like I said last lesson, I love looking after the elderly, especially as a HCA. I really love looking after the older people, but I don't think that I would want to work like in elderly care like for the rest of my life or whatever. Perhaps in future I might say, okay, I might, you know, work in elderly care for a bit, but I don't think I would want to work in elderly care like for the rest of my life. So yeah, that was my experience with geriatric medicine or care of the elderly. My next placement is obstetrics and gynecology. To be fair, I love female health. I love, you know, obstetrics and gynecology and things to do with pregnancy and stuff, and I'm so looking forward to it. Hopefully I can maybe like see a cesarean section or like a vaginal birth or something. I have witnessed a vaginal birth, like a vaginal delivery, so I wouldn't be too like feeling too sad if I don't see one, but hopefully I can see one again, and also a cesarean section. That would be great. But yeah, so I'm looking forward to that starting from Monday. Yeah, leave any comments down below, any questions that you have about my placement and about my experience so far. And yeah, thank you guys so much for watching. Have a lovely day and God bless. Bye.
Also in the name of Jesus, I'm free. Oh yeah, I am free. I found my freedom. Praise the Lord. Praise the Lord. It is a wonderful something. I am free. I'm just saying thank you. I am free. I found my freedom. Praise the Lord.